Pancreas and biliary tract disorder. The learning objectives for this module include differentiate between acute and chronic pancreatitis related to clinical manifestations, complications, and nursing management. Describe the clinical manifestations, complications, and nursing management, including surgical therapy of gallbladder disorders. As a review, the liver produces bile. The gallbladder concentrates bile, and bile is released into the intestine and is essential for the digestion of fats and fat-soluble vitamins. Cholecystitis, or inflammation of the gallbladder, is most commonly associated with an obstruction caused by stones or biliary sludge. Bacteria reaching the gallbladder via the vascular or the lymphatic route, or chemical irritants in the bile, can also produce cholecystitis. E. coli or salmonella are also common causative bacteria. Cholecystitis can be acute or chronic. Manifestations vary from indigestion to moderate to severe pain, fever, jaundice. Initial symptoms of acute cholecystitis can include indigestion and pain and tenderness in the right upper quadrant, which may be referred to as right shoulder and scapular pain. The pain may be acute and may be accompanied by nausea and vomiting, restlessness, and diaphoresis. Manifestations of inflammation can include leukocytosis and fever. Physical findings include right upper quadrant tenderness and abdominal rigidity. And manifestations of chronic cholecystitis typically include a history of fat intolerance, dyspepsia, heartburn, and flatulence. During an acute episode of cholecystitis, treatment usually focuses on pain control and controlling possible infection with antibiotics. There may also be maintenance of fluids and electrolyte balance. An NG tube may be inserted to decompress the abdomen. The patient may get anticholinergic and analgesic medications. And once the pain is controlled and the inflammation is reduced, dietary teaching must happen to teach the patient to follow a low-fat, high-fiber, high-calcium diet. Cholelithiasis, or gallstones, is the most common disorder of the biliary system. The exact cause is unknown, but there are several risk factors. The main risk factors are known as the 4 F's. And it can be that you are fair-skinned, meaning Caucasian, fat, 40, or sometimes you'll hear female or fertile. So the main risk factors are it's higher in women and more often in women that have had multiple children, over the age of 40. Estrogen therapy increases the risk factor. People with sedentary lifestyle. If it is in your family, you are more likely to have gallstones, and if you are obese. The stones may remain in the gallbladder, or they may migrate to the cystic duct or the common bile duct. This causes pain as they pass through the ducts, and they may lodge in the ducts and produce an obstruction. Small stones are more likely to move into a duct and cause an obstruction. Cholelithiasis may produce severe symptoms to none at all. Many patients have silent cholelithiasis. The severity of symptoms usually depends on whether the stones are stationary, mobile, or whether an obstruction is present. When the patient does experience pain, usually the pain is severe and it's in the right upper quadrant and may last for several hours. The attacks of pain frequently occur 3 to 6 hours after eating a high-fat meal or when the patient lies down. The patient may also experience tachycardia and diaphoresis. When there is obstructed bile flow, the following clinical manifestations may arise. You may have obstructive jaundice, dark urine, clay-colored stools, pruritus, intolerance for fatty foods, bleeding tendencies, or stratorrhea. An ultrasound will be the most commonly used to diagnose gallstones. Other laboratory studies will be done to evaluate the extent of the disease. You'll be looking at liver function. You may see increased liver enzymes, increased white blood cell count. If there's inflammation, you may see increased serum bilirubin levels, increased amylase if the pancreas is involved. Oftentimes, you may see an EKG ordered to rule out an MI or a chest x-ray to rule out pneumonia, because at times the patient may present with symptoms that may be confusing to the healthcare provider, whether the patient is having gallstones or an MI or pneumonia. An endoscopic retrograde cholangiopancreatography, or ERCP, allows for visualization of the gallbladder, the cystic duct, the common hepatic duct, and the common bile duct. During this procedure, iodine dye is injected into the duct while x-rays are taken. This way they can evaluate how the bile moves through the duct. This is the most definitive test, but it has to be used in caution with patients who have end-stage renal disease or allergies to the contrast dye. So for a patient that you're preparing to go for an ERCP, it is important that you verify that the patient does not have an iodine allergy, and you verify that their kidneys are functioning appropriately. Typically, the patient will be given a sedative prior to the procedure. Post-procedure, you will want to keep the patient NPO until their gag reflex returns. A complication that can occur from an ERCP is procedural-induced pancreatitis because of the manipulation of the bile duct during the procedure. Complications of cholelithiasis and cholecystitis include gangrenous cholecystitis, cholangitis, which is inflammation of the bile duct, biliary cirrhosis, pancreatitis, fistulas and rupture of the gallbladder, which can produce bile peritonitis. In older patients and those with diabetes, gangrenous cholecystitis and bile peritonitis are the most common complications of cholecystitis. Cholelithiasis, which is stones in the common bile duct, can also occur, producing symptoms of obstruction. Another complication is carcinoma. Nursing goals for the patient undergoing treatment for gallbladder disease include treating the pain. The patient will be NPO, which should help relieve the nausea and vomiting. If the vomiting is severe, they will insert an NG tube to remove any gastric secretions from the stomach in order to allow the small intestine to rest and the gallbladder to rest. The patient will be receiving IV fluids to keep the patient hydrated, and as the patient stabilizes, they will begin to start them on food. Of course, we start with clear liquids first, but eventually we would advance them as tolerated to a low-fat diet, receiving small, frequent meals. Medication management can include analgesics for the pain, anticholinergics to decrease the secretions and decrease smooth muscle spasms, antibiotics for the infection, fat-soluble vitamins. They may take bile salts, which will help to dissolve the stones. They also might be on cholestyramine or questrin, and that's to help decrease pruritus. And they might be on antiemetics if the patient continues to have nausea and vomiting. Treatment of gallstones depends on the stage of the disease. An ERCP with an endoscopic sphincterotomy may be used for stone removal. The ERCP allows for visualization of the biliary system, dilation, and placement of stents, and a sphincterotomy can be done if necessary. Special catheters with wire baskets or an inflatable balloon tip may be used to assist with stone removal. The endoscope is passed to the duodenum, and a knife is attached to the endoscope. The stone sometimes is left in the duodenum, and then it will pass naturally in the stool. If a stent is placed, it is generally removed or changed after a few months. Extracorporeal shockwave therapy is an alternative treatment employed when stones cannot be removed by endoscopic means. This procedure uses high-energy shock waves to disintegrate gallstones once they have been located by ultrasound. Usually takes about 1 to 2 hours for the stones to disintegrate. After they are broken up, the fragments pass through the common bile duct and into the small intestine. Laparoscopic cholecystectomy, or lap chole, is the treatment of choice for symptomatic cholelithiasis. Approximately 90% of cholecystectomies are done laparoscopically. Most patients have minimal postoperative pain and are discharged the day of surgery or the day after, and they can usually resume normal activities within 1 week. On selected patients, an incisional or open cholecystectomy may be performed. This involves removal of the gallbladder through a right subcostal incision. A T-tube may be inserted into the common bile duct during surgery when a common bile duct exploration is part of the surgical procedure. This ensures patency of the duct until the edema produced by the trauma of exploring and probing the duct has subsided. It also allows the excess bile to drain while the small intestine is adjusting to receiving a continuous flow of bile. As previously stated, the T-tube is inserted into the common bile duct. It allows for excessive bile to drain. This is done while the small intestine is adjusting to the continual flow of bile. Care for the patient who has had a laparoscopic cholecystectomy will include the usual post-op care. You will monitor for complications. You will advance diet as tolerated. But a common post-operative problem is referred pain in the shoulder because of the carbon dioxide that is used to inflate the abdominal cavity during surgery. It may not be released or absorbed by the body, and the carbon dioxide can irritate the phrenic nerve and the diaphragm, causing some difficulty in breathing. Placing the patient in the Sims position on the left side with the right knee flexed helps move the gas pockets away from the diaphragm. You also want to encourage deep breathing along with movement and ambulation. The pain can usually be relieved with analgesics. If a patient has an incisional or an open cholecystectomy, they will also receive the usual post-op care. In addition, we'll watch for urinary retention, post-operative paralytic ileus. The patient usually is NPO, and they may or may not have an NG tube to low intermittent suction. Typically, the NG tube will remain until the bowel sounds return. The patient may have the NG tube only during surgery to help decompress the abdomen, and then we'll advance the diet as tolerated. If a patient has an incisional or an open cholecystectomy and a T-tube is present, you'll want to make sure that you're able to maintain bile drainage. You'll observe the function of the T-tube, and you'll observe the drainage, looking at the color and measuring the output. You'll expect to see 500 to 1,000 cc's per day initially. If drainage stops abruptly, your first action would be to check for kinks in the tubing. There will be decreases in the bile drainage as bile drains into the duodenum. As this decreases and bowel sounds return, you may begin clamping the tube for 1 to 2 hours a day before and after meals, and you'll check to make sure that the patient is able to tolerate this. You have to remember that bile drainage is very caustic and can cause damage to the surrounding skin, so good skin care is needed. Once the T-tube is removed, you want to monitor for drainage obstruction, and you'd watch for signs and symptoms of jaundice or stools that are light colored, like clay. Discharge teaching should include dietary instructions. Most patients can tolerate a regular diet with no difficulties, but they shouldn't be instructed to avoid excessive fats. Weight reduction should also be suggested if the patient is overweight. Patients should take fat-soluble vitamins. You want to teach the patient for signs and symptoms of obstruction, need for continued health care, care for their incisions, whether they are a large incision or a laparoscopic incision. If they're sent home with a T-tube, they'll need instructions on how to care for the T-tube. If it's laparoscopic, they should know that it is normal for them to be bloated for several days, sometimes even several weeks. If they have an open cholecystectomy, they should know that they should avoid heavy lifting for 4 to 6 weeks. Unusual activities, including sexual activities, can be resumed once the patient feels ready, unless they've been instructed otherwise by their healthcare provider. Pancreatitis is inflammation of the pancreas and can be acute or chronic. The pancreas is both an endocrine and an exocrine gland. It controls blood sugar by excreting insulin and glucagon. It also secretes different enzymes into the ducts: trypsin for protein, amylase for carbohydrates, and lipase for fats. And these secretions are highly alkaline. Acute pancreatitis is an acute inflammation of the pancreas. The degree of inflammation varies from mild edema to severe hemorrhagic necrosis. With increased pancreatic destruction, there is an increase in severity. A patient can have complete recovery, recurring attacks, or can eventually have chronic pancreatitis. Acute pancreatitis can be life-threatening. Chronic pancreatitis is a continuous, prolonged, inflammatory, and fibrosing process of the pancreas. The pancreas is progressively destroyed and is replaced by fibrotic tissue. Strictures and calcifications may also occur in the pancreas. There are 2 types of chronic pancreatitis: obstructive and non-obstructive. The most common cause of pancreatitis is alcoholism. There are other contributing factors to pancreatitis as well, but other common causes would be gallbladder disease, specifically gallstones. It can also be complications of different abdominal surgical procedures and can be a complication of the ERCP procedure. With acute pancreatitis, signs and symptoms can include back pain, left upper quadrant abdominal pain, abdominal tenderness and distension, nausea, vomiting, bowel sounds may be decreased or absent, there may be jaundice. The person may have a low-grade fever, leukocytosis, and eventually may have hypotension, tachycardia, and crackles in their lungs. With chronic pancreatitis, the pain is usually similar to the pain in acute pancreatitis, but the pain is usually described as heavy, gnawing, sometimes burning or cramping. The pain is not relieved with food or antacids. Other manifestations include symptoms of pancreatic insufficiency, including malabsorption with weight loss, constipation, jaundice with dark urine, stratorrhea, and diabetes mellitus. The stratorrhea may become severe with large amounts of foul-smelling, fatty stool. Urine and stool may be frothy. Diagnostic testing for pancreatitis can include elevated amylase, lipase levels in the blood, as well as urinary amylase. Additional findings can include high glucose levels, low calcium levels, and high triglycerides. In addition to the elevated serum amylase and lipase levels, you may find elevated bilirubin, alkaline phosphatase. You may have mild leukocytosis, an elevated sed rate, and there may have stool samples are examined looking for fat fecal content. Additional diagnostic tests can confirm pancreatitis: a CT scan, an abdominal X-ray, an abdominal or endoscopic ultrasound, a magnetic resonance cholangiopancreatography, MRCP. An ERCP can be done, but we know can also cause acute pancreatitis if the patient doesn't already have pancreatitis. But the ERCP will be the best test to visualize the pancreatic and common bile duct. A chest X-ray may also be done to rule out any pulmonary problem. Treatment of acute pancreatitis will be to make the patient NPO. They may have an NG tube inserted. If the patient is going to be NPO for a prolonged period of time, they would be started on total parenteral nutrition. It will be important for us to manage our patient's pain. Oftentimes, IV pain medications are given. The patient may need antibiotics for the prevention or treatment of infection. We'll also be monitoring fluid and electrolyte balance to prevent shock. So the patient may be getting IV fluids. They may be getting a blood transfusion if they've had hemorrhagic pancreatitis. We will be monitoring their blood glucose levels, and most likely we'll be giving them insulin. And we'll be closely watching their potassium, their calcium, and their magnesium, and supplementing as needed. Because a patient who has pancreatitis is at risk for hypocalcemia, it would make sense to frequently evaluate hypocalcemia by either evaluating for the Trousseau sign or the Chavat-6 sign. This can be done every couple of hours to evaluate calcium levels. A complication of acute pancreatitis is a pancreatic pseudocyst, which is an accumulation of fluid, pancreatic enzymes, tissue debris, and inflammatory exudate surrounded by a wall. Manifestations of a pseudocyst are abdominal pain, a palpable epigastric mass, nausea, vomiting, anorexia. The serum amylase levels frequently remain elevated. A CT MRI or endoscopic ultrasound may be used in the detection of a pseudocyst. The cysts will usually resolve spontaneously within a week or two, but they may also perforate, which can cause peritonitis. Treatment options would then include surgical drainage, a percutaneous catheter placement with drainage, or endoscopic drainage. Another complication of pancreatitis is a pancreatic abscess, which is a collection of pus. It results from extensive necrosis in the pancreas. It may become infected or perforate into adjacent organs. Manifestations of an abscess include upper abdominal pain, abdominal mass, high fever, and leukocytosis. A pancreatic abscess requires prompt surgical drainage to prevent sepsis. Additional systemic complications of acute pancreatitis include pulmonary complications such as pleural effusion, atelectasis, and pneumonia, cardiovascular complications such as hypotension, and tetany can be caused by hypocalcemia. Nursing assessments should focus on pain, respiratory assessment and management, cardiovascular assessment and management, and GI assessment including input and output as well as nutritional intake. Treatment for chronic pancreatitis can include some of the same treatments as it is for acute pancreatitis. It depends again on the severity of the chronic pancreatitis. Most of the time though, we're focusing on providing comfort. So we're assessing pain, we're positioning our patients, suggesting a side-lying position with the head a bed up, 45 degrees, with the knees drawn in. We want to have suppression of the pancreas producing enzymes. So the patient may be NPO, but more often in chronic pancreatitis, the patient may receive 6 small, bland, low-fat meals a day, and they must be given their pancreatic enzymes with the meals. We also must manage and monitor for diabetes. Drug therapy for acute versus chronic pancreatitis is listed here for you. Most of the treatment for acute pancreatitis focuses much more on pain medication, where you can see when we move over to the chronic pancreatitis, it's much more on pancreatic enzymes and insulin. When the acute pancreatitis is related to gallstones, an urgent ERCP with an endoscopic sphincterotomy may be done. This may be followed by a laparoscopic cholecystectomy to reduce the potential for reoccurrence. Surgical intervention may also be indicated when the diagnosis is uncertain and for patients who do not respond to conservative therapy. Those with severe acute pancreatitis may require drainage of necrotic fluid collections. This is done either surgically or under CT guidance or endoscopically. Percutaneous drainage of a pseudocyst can also be formed, and a drainage tube will be left in place. Following surgical therapy for acute pancreatitis, the patient will receive usual post-op care. Know what surgical procedure the patient had and how much tissue was removed. If the patient has drains present, know the purpose and the location and monitor these drains at least once a shift. If the patient has T-tubes or stents, watch for leaking or non-functioning tubes and wonder why aren't they functioning. Assess for peritonitis and possible fistula formation. You'll be monitoring blood sugars. You want to control with diet if you can, possibly administer insulin, and watch for signs and symptoms of hyper and hypoglycemia. Patients with chronic pancreatitis have to have control of their pancreatic insufficiencies. To do this, they must be instructed to follow a bland, low-fat, high-carbohydrate diet. They need to take their enzymes with their meals. They also should take acid-neutralizing and acid-inhibiting drugs, such as H2 receptor antagonists or proton pump inhibitors. They need to control their diabetes, avoid alcohol, and also be given information on smoking cessation. Patients discharged from the hospital, whether with acute or chronic pancreatitis, also will need to know how to care for their drain if they are sent home with a drain. They may need to know about future surgeries that they may need to have. They need to know the signs and symptoms of an acute and a chronic exacerbation. And this teaching should include the family as well.